invite Dr. Adreesh Mukherjee for the workshop on botulinum toxin headache. Adreesh is a very close senior to me and we have been since our MD days. It's a proud privilege to have him here and so happy and lucky to see him back again. Thank you.
Thank you, Pratim, and thank you to all the organizers. Volunda is also there. Good evening, everyone present. I think this is the last session of today. Ashish sir is also there. Good evening, sir. So I have a different topic because Pratim asked me to talk about botulinum toxin injection in migraine. So there may be some controversies, but I'll try to keep it as straightforward as possible. So the first disclaimer that I'll give is that the brand names used in this lecture is only for educational purposes. Why I'll just elaborate later. So if we go to the ICHD3 criteria which we all follow, we can see that migraine, it is migraine without aura, migraine with aura, then so many things. What we are concerned regarding botulinum toxin injection is chronic migraine. Now, what is the how do we define chronic migraine? So it's more than equal to 15 days of headache per month for more than 3 months. It is interesting to note that not all the headache episodes will be like a migraine, but the migrainous headache should be at least 8. So the rest of the headaches may be non-migrainous in semiology also. Now, episodic versus chronic, initially most of the migraine patients present as an episodic migraine. So that's more than 5 or more attacks lasting for 4 to 72 hours with photophobia, phonophobia, nausea, vomiting, we all know that. Now, then in some patients, it becomes persistent. So the headache is not going away. Then we think that maybe the patient is landing in chronic migraine when it lasts for more than 3 months. But there is another entity which we should not miss, that is the medication overuse headache. So the patient is taking all the acute medication repeatedly, the triptans and everything, and then they say that the headache has become chronic. So maybe the patient has ended up in a medication overuse headache. So that we have to be careful before proceeding. Now, briefly, I think this has been discussed today morning also, the pathophysiology of migraine in this beautiful article in NEJM. So, structurally if we see, so the trigeminal vascular pathway is responsible. We know that the afferents, they carry to the trigeminal ganglion and then to the brainstem nucleus and then to thalamus and then to the somatosensory cortex. Now, if we go to the molecular level, which is I think most of the newer modalities are coming up in this, we see that a lot of things are going on around the CGRP receptor. So, the final common pathway they have said is the potassium ATP channel, which leads to vasodilatation, the symptoms of migraine. But if we see that it is ATP dependent, and here comes the role of the CGRP receptors. Now, why this is important in this talk? So we know that botulinum toxin, we all know it's a neurotoxin derived from Clostridium botulinum. It inhibits acetylcholine release at the neuromuscular junctions. If we go to the list of the indication, aesthetic, all the cosmetic purposes, therapeutic, hemifacial spasm, the dystonias, spasticity, and chronic migraine. This is the usual mechanism of action that we teach. That the snare proteins, the synaptic vesicle, they are not getting released, so the acetylcholine is not getting released, and so on and so forth. But how does this work in migraine? It is a little bit different. Here comes the role of the sensory pathway. So now we know that the botulinum toxin also has an effect on the sensory pathways. Now that is by modulating CGRP, substance K and glutamate neurotransmitters. So again there is a common pathway CGRP. What happens? This reduces the hyperexcitability and there is a role in peripheral and central sensitization. Now recently even in dystonia we now say that the effect of botulinum toxin is one in the neuromuscular junction and it has also an effect on the neuroplasticity which goes on in the dystonia patients. So the sensory component is already there. Now botulinum toxin is also used in some neuralgias, refractory trigeminal neuralgias we are using. We are utilizing the sensory pathway now. Now, why this is important, the types of botulinum? Because we say botulinum toxin, there are so many types. For chronic migraine, till date, the approved type is monobotulinum toxin or Botox. That was approved by the US FDA in 2010 and it was adopted in the NICE guidelines in 2012. Now, it was based on this study, basically, the PREEMPT study, which has been discussed so many times. I will just give the brief about it. Monobotulinum toxin was injected at 12 weeks interval. That was a placebo-controlled trial. And then there was an open-label phase for 3, 4, 5, 3 more injections. What they saw is that at 24 weeks there was significant decline in the frequency of headache days. If we see with placebo it's around 6.5, with Botox it's around 8.5. This was statistically significant, but there were some adverse effects, of course, neck pain, some weakness, some ptosis was there, but it was less than 1%. So this proved that it is effective in chronic migraine. But we should remember, we should always take a thorough history of clinical examination, including the fundus. We should identify chronic migraine and medication overdose headache. Then we should discuss the available therapeutic modalities with the patients and their relatives regarding availability, efficacy and cost. All these three things are important. Then we should set rational goals and expectation. We should not claim that this is a magic drug. We will inject and it will go away. The goal should be rational. There has to be informed consent. We have to maintain a headache diary, and we have to stress on lifestyle modification, management of the oral medications. Then we have to document the doses and follow the correct dilution. So this is the equipment which we need: 1 ml tioproline syringe and 30 gauge needles. These are very, very fine needles so that the pain is less. And remember, in contrast to the cervical dystonia injections where we use a IM needle and we go deep in the muscles, for headache we usually use superficial injections. So we use these needles. The reconstitution is a preservative-free normal saline. We know we will avoid vigorous shaking. Aseptic technique: 4 ml saline for 200 minutes of Botox. That means each ml has 50 units. That means each 0.1 ml has 5 units. Why this is important? Because in the pre-em protocol, we will inject at 31 sites across the head and neck, and at each site there will be 5 units. So 0.1 ml to be injected at 31 sites. Now, we will follow up the patient at 4 weeks and we will re-inject the patient at 12 weeks following the protocol, and then at 24 weeks we will know actually how much it has worked. Now, these are the sites where we inject. One is from the anteriorly and one is from the posteriorly and one laterally. This is how we see three-dimensionally. If there was a patient, I could have demonstrated, but I'll try to do it in this slides. So his corrugator is just above the brow, medially, 2 sides. Procerus is the midline structure, midline muscle. Then is the frontalis. Frontalis we inject on 2 sides each side. How do we check for the 2 sides? First of all, we will avoid the lower part so that there is no brow ptosis. We will inject in the upper third of the forehead. And then the first side will be directly above the corrugator side. The second side will be along the limbus line. That is the cornea, the outer side, that is the limbus line. That will be the second side. So 2 on each side. Right. And another thing important is the direction of the needle. For the Procerus we use a perpendicular 90-degree needle, but for the frontalis we use a 45-degree needle. So here we will inject like this, here we will inject like this. Then comes the temporalis. So temporalis we can feel on either side. We will ask the patient to cleanse the teeth and we will know that where the temporalis is. Again 4 sides. How do we see the 4 sides? We go to the tragus, we go up around 2 finger breadth. That is the first side. Then if we see, we will go higher up, that is the second side. In between the 2 sides, we will go 1 finger breadth anteriorly, that is the third side. And from the second side, we will go 1 finger breadth posteriorly, that is the fourth side. So 4 injections in temporalis on either side again. So this is frontalis and this is temporalis. So now we will go to the back. In back we will inject, so the occipitalis. Occipitalis, this is a very interesting technique which they say. We will just see the mastoid and the inium. In the midpoint, we will go above the nuchal ridge. So there is the occipitalis attaching like this. So that is the first injection. Then we will go like this, V-shaped, 1 finger width on each side. So these are the 3 sides for the occipitalis, 3 on each side. Then we go to cervical paraspinal. That is just 1 centimeter from the midline. Again, we will try to inject within the hairline and we will try to avoid the lower neck. And then again, midline 1 centimeter, then again V like this on each side. Complete cervical paraspinal. Last is the trapezius. Trapezius injections will be superficial, not like the cervical dystonia patients where we go deep into the trapezius. Here it will be a little bit superficial and we will give a very narrow angle for the injection. Like this. So for the trapezius, how we will inject? We will again this inflection point where the horizontal and vertical fibers meet of the trapezius. That is one point, the joint is the other, midpoint is the first injection. Then we'll divide it into two parts, one here and one here. So that's 3 injections in the trapezius on each side. So in this way, we'll have 155 units injected. I mean, some of the patients, there may be additional units required. We can go up to 195 units. Here we call it follow the pain. So if the headache is more on the right side, we'll inject the 2 temporalis. If there is more of the posterior side headache, then we'll inject the occipitalis or the trapezius. It is called follow the pain. It has to be individual. It is not that we have to go up to 195. The range is 155 to 195. Usually we start with 155. Okay. So this is how we approach. We first diagnose that it is chronic migraine. Then we rule out the secondary causes. So a patient, we have all been taught, if there is a change in the character of the headache, we should always rule out secondary causes, even in a patient who is a known case of migraine. Third step is take the general measures, and that is very important to avoid medication overuse, MOH. Then we will go for the acute treatment and the preventive treatment. Again, the first line, it has been shown in studies that maybe topiramate acts a little better in these patients compared to the other. But it can be individualized again. If this trial fails for 2 to 3 months, then we discuss with the patient that now there are 2 things we can do. Either we can use the CGRP monoclonal antibodies or we can use the Botox. And we have to again discuss everything, availability, cost and efficacy. And then so it is always an informed process. Now we wait, and if it still fails, then we go to the next side, which is the refractory management, where you have to take help of a headache specialist, like sir is sitting in front of us. So that is how I approach a case of migraine, and only after crossing all these 5 steps, I counsel a patient for a Botox injection. Thank you so much.
You would like to comment?
I have a comment. In the refractory cases, you have mentioned there are 2 options: that botulinum toxin versus CGRP antagonist. The botulinum toxin primarily acts on the C fibers, and the CGRP acts primarily on the A delta fibers. So in future, there may be a possibility of combining both when one of them is not working.
Yes, sir, and this is already being planned.
Yes.
I think, sir, no, this is already being planned. Combination.
There are studies.
Yes, sir, this is already there. Combination.
I'm Dr. Sujata Sharma. I'm rehabilitation physician in this institute. We are practicing botulinum toxin injection in chronic migraine. So my question is, you are using a 30-gauge needle. Will it suffice for a healthy, bulky patient for trapezius?
Right. So I knew. So for the trapezius, so the other sides we know it's easy. We can do with the 30 gauge. For the trapezius, we have to again individualize. So if that's a very bulky patient with a very stout trapezius, we may need to take help of an iron needle. But in that case, again, we have to understand that the injection should be superficial, not like a distal, that we will not go down straight like that. And if there are trigger points, it's better to avoid that. But in most of the, to be very frank, the way I manage a patient, if I say my experience, when I see a patient, I think sir will also share their experience because they have a 10 or 15 minutes time with us. When I see a patient of chronic migraine, I don't jump to Botox. First I see that what it is. Just this flowchart, actually, I made this flowchart according to what I do actually. This is not from any book. This is exactly what I do. Then I check the fundas, then I see whether I am missing something. Then why I'll tell you. So recently I saw a patient, just 3 months ago. This patient was seen as a patient of migraine in pre-COVID, some neurologist. That was migraine. Even I took the history, that was like migraine. A CT brain was done, that was normal. Then that patient visited me in January. I think 8-9 months ago. She was having severe headache now. Now when I saw the patient, I asked her to do an MRI. She told me that the CT is normal, she was on rural area. I have migraine, that why should I go for MRI? I told her there are some findings, you should go for the MRI. Now again she came after 8 months, she was totally okay. In 8 months there was no headache. She was doing well. Then I told him, please go and get the MRI done, you have something. This is why. I always tell my patients, I am not just saying that. You have this change in your fundas. I explained everything, but as usual, there was the level of migraine. She was reluctant. Then I asked her, please go and do the MRI. And it turned out to be a pituitary lesion. The patient had a significant pituitary lesion there. So that's the first step. Then I always rule out medication overdose. Not only rural areas, even when I practice in urban settings, I see a lot of patients who are overusing the acute medications. Even office goers, in the morning they will just take a pill and they will go to work, because they say otherwise I can't work. If just moment I start my desktop or laptop, I start having the headache. So that is one thing. So after doing this, I think if I see 50 patients of chronic migraine or 10 patients of chronic migraine, I think I am left with only 2 or 3 patients who really require that next step. Otherwise, with proper dosage modification, proper lifestyle modification, proper diagnosis, that is my experience. Our seniors are here, they will also share their experience. Then of those 2 to 3 patients, then I counsel these are the options. Then just hearing the cost, some of them back off. Then I am left with maybe 1 patient who will go for. That is my practice. I mean, in a specialized institute, definitely will be injecting more patients. But the response that I got is actually positive when I injected. So there are 3 patients right now in follow-up who were getting it injected and they are doing well.
So we get different kind of distribution in migraine headache. So for facial symmetry, we inject both the sides. But for other sides, do you inject bilaterally on this?
So what I do actually, so this is a very interesting question. So there were some, this dosage on chronic migraine, there were some debate regarding whether we can go down, whether we can go up. What I do, I follow the pre-end protocol. When I'm starting injecting, I follow the pre-end protocol. Because I just want to go for the sensory, the sensory pathway. I go for the pre-end protocol, 2 injections. Then I start follow the pill. The second part I do later. I don't do it from the first time. That is what I practice. I first inject according to the pre-end protocol, 12 weeks apart, then I see the response, then I follow. That is what I practice.
Any comments on
So just what is it about the fact that injecting both the sides? So pre-end protocol is the one which should be followed, as you said that at least for the first 2 times. Later on, what many people do, especially in the West, even sometimes we also do, there are other techniques also, like one is an anatomically regionally targeted technique, then there is follow the suture technique, in which you can give lesser amount, but that is not what is proven for all patients. So after that, you can probably, if the patient has headache more on one side, or there may be some patients who have a nubular headache, for that you can give just in there. And if they are having more of a frontal headache, then you can, and less of occipital headache, you can decrease the dose in the occipital region. And many patients will require extra dose like 195 units. Some patients may not have a good effect for the whole 3 months. So they may, in the last 2-3 weeks, they return back with severe pain. So in those cases, especially 195 units, would be better injected into the temporalis occipitalis and trapezius. So the dose modification should be only done after at least you have given at least 2 trials, not before that. And otherwise, follow the pre-end.
Thank you, sir. Thank you.
Kindly come up. May I request